Hi there, and welcome back to this second masterclass in the series on thromboembolism. I'm Russell O'Brien, I'm a consultant in acute medicine at the RD&E Hospital in Exeter. In this first of three subsections, we're going to look a little bit more at Virchow's Triad. We spoke about this in the last masterclass, and in particular in response to venous blood stasis. This is aimed really at sort of middle to more senior students overall, because we're going to introduce some slightly rarer cases and slightly more unusual cases to build on things that you may have seen in the past regarding things like DVT and pulmonary embolism, which you'll be very familiar with. So I'm going to use a couple of cases just to illustrate that venous stasis is a very potent cause of thromboembolism. The stasis itself can be either arterial or venous, and we've got a case, I think, in each category here. So venous stasis is very common after things like periods of immobility. So this is why people develop DVTs and pulmonary embolism after long-haul flights. And a very, very common cause in hospital medicine is patients who've had recent surgery and have been quite immobile on the wards. That's particularly common if you've had major orthopedic or pelvic surgery. And something that we'll come back to a little bit later in terms of hypercoagulability, patients with cancer and some kind of obstructive lesion are particularly prone to venous stasis as well. Arterial stasis is also very important, and we'll have a case to start with on that. So I'm going to talk a little bit about Alan, who's in his late 60s at the moment, and he's a long-time arteriopath. It's a rather unflattering term for somebody with extensive arterial disease and moderate hypertension. And he comes into hospital and he's really looking very ill. He's got terrible abdominal pain. He looks hypotensive. He just looks dreadful, and he's very tender in his abdomen, and recently has had some slightly bloody diarrhea as well. So there's a fair range of differential diagnoses here, and we're obviously focusing on one particular case, but just have a think, what kind of conditions would you expect somebody to have, essentially an acute abdomen with bloody diarrhea, and in a man of his age. He has a blood gas done because he's ill, and just let you have a look at that before I kind of highlight some of the areas. But you can see that he's got a pH of 7.27, so he is acidotic. He's also got a low CO2, so he's probably hyperventilating to blow off acid, and his lactate is very, very high at 8.5, and similarly a bicarbonate is very low at 10.2. So he has got a severe metabolic acidosis that's no longer compensated. He's trying to blow CO2 off in order to improve his pH, and a lactate of 8.5 is very, very bad. There's a slightly unpleasant rhyme of a lactate of 7 goes to heaven. So this is a really high lactate. So something is really hypoxic, something is not getting oxygen, or is very septic. Those would be the kind of things that you would think about with a blood gas that look like this. But whatever the cause is, he is in really bad shape. So what could be going on here? Well, that's his ECG, and I don't suppose you can see it terribly well just looking at it on the screen there. So we'll move on just a little insert there. So this is just looking at the rhythm strip, and you can see that he's got a very wandering baseline. There's almost a sawtooth appearance to it. So this is certainly pushing you down the view that this patient might be in atrial flutter or fibrillation. Now that's a common condition anyway, and it may not be relevant. But with that story and someone in atrial fibrillation, then one of the things we really need to consider is whether they've had an acute bowel thromboembolism, so a mesenteric embolus or in the celiac axis. So it's quite an unpleasant condition, acute bowel ischemia. There's a very high mortality from it, and it tends to happen more in the very elderly. He's a little on the young side, but with all of his vascular risk factors, AF and peripheral vascular disease, he's going to be vulnerable to this. It could be an in situ thrombus, or it could be an embolus from somewhere else, and it can go down any of the bowel arteries. And the features that we've just seen, an elderly patient in AF with vascular disease who presents with tummy pain, possibly bloody diarrhea, an acute abdomen with a metabolic acidosis is certainly someone you should consider this in. And it has got very serious consequences, and patients sometimes might need life-saving surgery. They would need antiplatelets, anticoagulation, and maybe revascularization as well. But whichever way you look at it, the mortality of this is pretty high. At 69, you would hope that people might take a chance on him for a surgical intervention, but often you see this in extremely frail and comorbid patients where surgery would be less likely to be effective or safe to proceed to. So what's happened for Alan? Well, he's in atrial fibrillation, and if this is an embolic cause, then it's probably come from the left atrial appendage. The left atrial appendage is a little sort of outpouch, you might say. It's a remnant, and it's very muscular and in terms of the shape of its wall. But blood doesn't flow very well through it, and in particular, if you go into atrial fibrillation, blood can even stagnate in this little corner of the atrium. If that happens, you can have a clot form in there, and clearly, if that is to break off the left atrial appendage wall, then that can embolize, and the most common syndrome is obviously a stroke when it heads north into the head and neck and causes, for instance, a middle cerebral artery occlusion. But it can go down a leg and cause acute limb ischemia, and in other circumstances end up in somebody's mesenteric or celiac artery and cause acute bowel ischemia as well. If we look at a scan, an echo of the heart, you can see that there is a clot in this person's left atrial appendage, and there's the left atrium just to the left of it on there. So this can be diagnosed on echo, and is a common cause of thromboembolism in patients with atrial fibrillation. So worth knowing about. The second case, this is a relatively rare problem, but the story of this, and this is a paraphrasing of a case I heard from a neighbouring hospital, is about Kyle. So Kyle was watching the football while his wife was out, and he leaned into the lower part of the fridge, you might be wondering why I'm saying this, to grab a beer out. And when his wife came back later, he was slumped on the kitchen floor, dysphasic, confused, mumbling, and also had a right facial droop and what looked like a hemiplegic stroke on there. He's young, his blood pressure's normal, his ECG is normal, his cholesterol's normal, there's no family history. So you might say, why on earth would Kyle have a stroke at that age? And there's a clue in the story here, and that's that he had a congenital heart lesion that has predisposed him to a stroke. So he has got probably a patent foramen ovale. And what's happened is he's had some clot in his venous circulation, not necessarily a large clot like a DVT, although it could be. And as he's bent down and strained to reach the back of the fridge, he's put his right-sided heart pressures up. And because he's been born with this patent foramen ovale, and normally the flow would not be from right to left, he's given himself essentially a Valsalva maneuver that has increased the right to left shunt, and a small clot has gone through into the arterial circulation and caused a stroke. And so this is something to consider, particularly in patients who are younger, who present with some kind of stroke syndrome, and it is worth considering whether you do echocardiography in people when you really don't know why they've had a stroke at a young age. As a minor aside, these are actually easier to treat, or at least the PFO is, the patent foramen ovale, and you can do it with something called an Amplatzer occluder, and these are actually done all percutaneously and can actually shut off that patent foramen ovale and prevent further emboli during periods of essentially a Valsalva maneuver. Apart from that, obviously, we would treat this in the same way as a DVT or a PE, because this is actually a venous thromboembolism. So there's a couple of cases there that just illustrate venous stasis, and as I said at the start, I've intentionally chosen a couple that are slightly stage above and slightly rarer than some of the things you may have covered in the early years of the course. In the next masterclass, we'll just look briefly at what endothelial damage means in the creation of thromboembolic disease. So I'll see you there. Thank you very much.